Bismillahirrahmanirrahim. Rabbi shrah li sadri wa yassir li amri wahlul uqdatam min lisani yafqahu qawli. So, as we have discussed about the skeleton of the chest wall, that is the ribs, vertebrae, and joints of the chest wall, the joints of the ribs with the sternum and with the vertebra, and then now we are able to discuss about the respiratory movements. Before we start the respiratory movements, the axis of movement in the previous slide, I want to show you that here is the axis of movement that passes through the costotransverse joint and costovertebral joint. It's a tubercle joint with the transfer process of the vertebra and the tubercle of the rib. And here is the joint between the head of the rib and the uh, facet over the vertebra. And here is the axis which is passing around this axis. The movement, two movements they are occurring. One is here that will increase the transverse diameter, and here is the movement from anteroposterior which will increase the anteroposterior diameter. So, movement of the thoracic wall and diaphragm during the inspiration produce increase in intrathoracic volume and diameter of the thorax. So if you have tried at any time that you have inflated the balloon with, although you are inflating it with the positive air pressure from your chest cavity into the balloon, but balloon expand in all the directions until and unless it is limited to expand in some direction, otherwise expand in all directions. So it means that all the directions that anteroposterior, transverse, vertical, all the diameters, the lung will expand, and this will occur due to the this will cause the difference in the intrathoracic volume, means volume of the air in the lungs. The pressure changes that result in the air being alternately drawn into the lungs during inspiration through the nose, mouth, and larynx and trachea, and these pressure changes they throw the lung air out of the lungs by the process of expiration through the same passages. During the passive expiration, diaphragm, intercostal muscle, and other muscle relaxes, causing intrathoracic volume and decreasing the intrathoracic volume and increasing the intrathoracic pressure. So what this sentence means is that inspiration is an active process during which the action of diaphragm, intercostal muscles, contraction of these muscles causes increase in intrathoracic volume through decreasing the intrathoracic pressure. But during expiration, it is a simple relaxation of diaphragm, intercostal muscles, and other muscles that will cause the expiration. Intra-abdominal pressure decreases and abdominal viscera are decompressed. This allows stretched elastic tissue of lung to require and expelling most of the air out. Okay, now before we go to the movements of the chest wall and that occurs and causing the changes in the diameters, I think so we should have an idea what actually causes the movement of the air into the lungs and out of the lungs. First of all, keep it in mind that lungs is a recoil, has a tendency to recoil. to become smaller, and it's an elastic tissue, and it has to be kept open. The alveoli, they tend to collapse due to the elastic recoility of the lungs, but they are kept open by the thoracic wall and pressure in the thoracic wall. So how is it is done? First of all, see here that actually the benefit of rib cage muscles, action of rib cage expand as these rib muscles contract. Rib muscles, when they contract, they causes the expansion of the chest wall in all the direction, anteroposterior, transverse, as well as in the vertical direction. The contraction of diaphragm, it moves down and it will increase in the vertical diameter. So what happens then? When this increases, it causes the expansion of the lung. And during acceleration, there is simply relaxation of the muscles of the chest wall, the rib muscles, and the diaphragm muscle relaxes, causing the exhalation. Now, what happens? The pressure outside is 760 millimeter of mercury. But here is a cavity which is between the parietal pleura and visceral pleura. Here you see the pressure is 756 millimeter of mercury. So the difference is of 4 millimeter of mercury. The normal difference. Intrapulmonary pressure means pressure within the trachea, bronchi, bronchiole, and alveoli is equal to the atmospheric pressure, 760 millimeter of mercury. But the pleural cavity pressure between the parietal pleura and visceral pleura is 756 millimeter of mercury. 4 millimeter of mercury difference. This 4 millimeter mercury difference, it is this pressure that keeps the lung expanding even if you are not breathing. There is no breathing, but the lung, they remain expanded because of this pressure difference. The low pressure in the pleural cavity, 756, 4 millimeter difference, that keeps lungs expanded, not allowing them to recoil. Now what happens is that when this pressure is a negative pressure, the pressure within the pleural cavity due to visceral pleura adhering to the parietal pleura is always negative respect of atmospheric pressure, and this pressure within the alveoli and the lungs, the atmospheric pressure, intrapulmonary pressure. This opposes the elastic recoil of the lungs, keeps the lung attached to the thoracic wall and diaphragm at least partially inflated, not collapsed at all times even after exhalation. And what we understand that actually when the chest wall muscle, the rib muscles and diaphragm, they contract and increases the thoracic cavity volume, both anteroposteriorly, transversely and vertically, they actually decreases further the pressure in the pleural cavity, which was -4, you can say, increases up to -6. And this -6 pressure causes further expansion of the lung tissue. So creating a sucking air from the trachea, bronchi, bronchioles into the alveoli. Because when it will, this negative pressure, -6, will cause a negative pressure, and it will cause further expansion of the lungs. That will create another pressure. Same pressure is reflected in the alveoli, decrease in the pressure, that will cause a suction effect. So basically it is the difference in the pressure in the pleural cavity from -4 to -6 that causes inflation of the lungs. And this pressure, negative pressure, is created by the movement of the chest wall, by the rib muscles and the diaphragm. If we have this concept in mind, then now we can understand the movements of the chest wall and respiratory movements that in the first diagram, here is shown that a rib is attached to the sternum and is posterior end through the head to the vertebra. So this rib is sternovertebral rib. So what is happening here is that the sternum is moving a little bit, because we know that manubriosternal joint is secondary cartilaginous joint, and small movement can occur here up to 7 degrees movement can occur here. So it's causing the body to move forward, and when it moves forward by contraction of the rib muscles, it acts like the handle of the pump, and the rib is the fulcrum of this handle. When it moves, you consider this sternum as a hand, and this is the fulcrum of the pump. And when this move forward, it causes an increase in the anteroposterior diameter. So this movement is occurring at the pump handle movement is occurring at the vertebrosternal ribs, where the anteroposterior diameter is changing. In the second diagram, we are seeing that the one part of the rib is attached to the vertebra behind, but the anteriorly it is attached only to the with the chondral joints of the above rib, means that lower ribs. So when that moves, here you see it is moving like the handle of a bucket from below upward. When it moves up, because it is in oblique, moves up, it causes in the difference in the diameter of the transverse diameter of the chest wall. So these movements, because they are occurring at the vertebrochondral ribs, so lower ribs, and this is buccal handle movement, and this is causing increase in the transverse diameter of the lungs. Here is in this diagram also shown. Here is shown the anteroposterior diameter changes of the chest wall, and here is shown the transverse diameter of the. Here both at the same, because both movements are occurring at the same time, here is shown the both movements of the chest wall, buccal handle and pump handle movement. The third movement is the diaphragm. Diaphragm, when contracts, it moves downward. When it moves downward, it causes in the expansion of the vertical diameter of the chest cavity, pleural cavity. Vertical diameter, it increases. So you can see here, this much difference is here. So the movement of the diaphragm during the respiratory movement causes difference in the, when it contracts, it increases the vertical diameter of the chest wall. So what we have understood is that through the pump handle movement is the anteroposterior diameter which is changing, and it is occurring mostly at the vertebrosternal ribs, mostly. And here we see that the transverse diameter, it is increased by the buccal handle movement, and it is occurring mostly at the vertebrochondral ribs. So, pump handle movement. Elevation of the ribs increase anteroposterior diameter of the thoracic cavity. Here is shown. Buccal handle movement, elevation of the ribs, increase in lateral diameter of the thoracic cavity means transverse diameter of the ribs. And we have seen that it is occurring mostly, although there is in the above ribs, also there is increase in the transverse diameter, but mostly this is occurring at the vertebrosternal ribs, and this movement, buccal handle movement, is occurring at the vertebrochondral ribs. And we have seen in the previous slide that the vertical diameter is increased by the contraction of the diaphragm. So, movement of the rib cage during the inspiration has been shown here, and here is shown that the movement of the diaphragm. So, this causes further decrease in the intrapleural pressure, means pressure in the pleural cavity from -4 to -6, which causes further expansion of the lungs. Keep it in mind that lungs, they are kept expanded by the negative pressure in the intrapleural cavity of -4 millimeter of mercury. Okay, so here is the pump handle movement shown again to show you that increase in the anteroposterior diameter of the chest wall. Movement of the diaphragm is called contraction, descent diaphragm, increase in vertical diameter of the thoracic cavity. Relaxation of the diaphragm is the expiration. So it's a relaxation of the diaphragm. It's not the, what you can say is that inspiration is the active process, while expiration is the passive process, is the elastic recoility of the lungs, which tend to recoil back, but they are kept open by the -4 pressure, normal pressure in the intrapleural cavity. This is normal respiration in the spine position. You see normal respiration. Here is the normal expiration. Inwards movement of the abdomen during inspiration. Abdominal paradox. You can understand very well that when inspiration will occur, diaphragm will move down. So it will cause an increase in the pressure in the abdomen, and abdomen will also expand. The abdominal wall will protrude out. This is the normal one. And during the normal expiration, both things at the because it relaxes, goes back to the diaphragm normal position, so the abdomen comes back. Okay, but in the abdominal paradox, what is occurring that during inspiration, although the diaphragm should move down and cause the expansion of the abdomen or the protrusion of the abdominal wall is moving inside. This is called as abdominal paradox. That is reverse movement of the abdomen as compared to inspiration and expiration. So when there is a rib cage breathing, that's the thoracic breathing, the abdomen is not seems to be moving at all. So only the chest wall is moving. But when we see abdominal movement, where you may have seen some persons lying down and their abdomen is moving outward and inward during inspiration, and their chest seems to be moving not at all. Otherwise, in the normal persons, this movement will occur during inspiration and expiration. So, two kind of movements, that is thoracic and abdominal. This is abdominal thoracic. This is abdominal. This movement is mainly thoracic, and this movement is mainly abdominal. And this is abdominal paradox. This difference you may feel in the females. Inward movement of the abdomen during inspiration rather than normal outward is called as abdominal paradox. The etiology, ineffective or ineffective breathing pattern. No specific indicator of severe pulmonary distress or severe respiratory distress. The females, normally there is the thoracic respiration mostly. Now we have understood about the movement of the chest wall and mechanism of the movement of the chest wall and why this is occurring, how many diameters are they are changing, what is causing changing in the diameters and pressure changes. Now are the muscles of the respiration. There are accessory muscles of respiration, means they are not attached. The axio-appendicular muscles, the muscles which are attached to the chest wall and the upper limb. Primarily, they are primarily the muscles of the upper limb, but several of them, such as pec major, pec minor, serratus anterior, they may act as the accessory muscles of respiration, helping elevate the rib cage to expand the thoracic cavity when there is inspiration in deep, forceful inspiration. Here is example given 100-meter dash race. So you may have observed it yourself when you run, when you are playing and you come breathless, then you put your hand over your knees, put your hand over some thing, over the bench or over the chair, and breathe deeply, trying to inhale the air forcefully. And during that process, actually, you are using the fixing the limbs with that object over the knees or over the table or over the chair. Your hands and your upper limb is fixed. Now, when the muscles such as pec major, serratus anterior, pec minor, they will act, they will actually cause the expansion of the chest rather than movement of the limb, because you have fixed your limbs over your knees or over something that you are holding with your hand forcibly. Similarly, the scapularis muscles of the neck, we descend from the vertebra to the neck, first and second, are primarily on the vertebral column. They mainly act on the vertebral column. But, however, they act as accessory muscles by fixing these ribs and enabling the muscles connecting the ribs below to move effectively in elevating the lower ribs during forced inspiration. So it means that first rib and second rib, they are actually fixed by the scapularis muscle, which are muscles of the neck actually, and they are more, their actual action is over the neck. But when you need forceful inspiration, and you may have observed also in that when you are inhaling forcibly, your neck muscle, they are also contracted. You can feel them. So it's actually to fix the first and second rib so that the lower ribs, they can move effectively. These are the actions of the accessory muscles, and these muscles, their origin, insertion, their nerve supply action on the limbs, you have studied in the upper limb also. So here is shown the accessory muscles of respiration. Here are the scapularis muscle of the neck, pec major, as pec minor and serratus anterior muscle. They are shown here, and again with that is the abdominal muscles, also the external oblique and rectus abdominis. They are also attached to the lower ribs, so they may be named as accessory muscles of the respiration. Also here muscle shown subclavius, which originates from the lower inferior surface of the subclavian groove of the clavicle to the first rib. So the accessory muscles, serratus posterior superior, serratus posterior inferior on the back, levator costrum, transverse thoracis, these muscles are concerned with the ribs and the innermost, then the subcostal, and then the transverse. These are the muscles of the respiration, actually muscles of the respiration, and here are shown their attachment, superior, inferior, innervation, and main action. Now, in the further lectures, we will see the attachment of the intercostal muscles and their actions, how they act, and then we will see the diaphragm also in the next lecture. Till then, Allah Hafiz.